Traditionally, in all honesty, we probably have not identified patients who had METex 14 skipping. The tests that we had routinely used to identify mutations in lung cancer patients, at least historically, generally would not pick up these mutations. So most of these patients would have received chemotherapy, potentially immunotherapy. The data is at least suggestive to date that this is not a group that derived particular benefits from those other standard therapies. There are no approved inhibitors of MET exon 14 skipping at the time that we're speaking, at least right now, about this. There are some drugs that are approved in other indications that people have used off-label to treat MET exon 14 skipping. The most common, I think, that ends up being used is Crizotinib. When I started working with Crizotinib in the laboratory, we actually called it Pfizer's MET inhibitor because it was originally being developed as a MET inhibitor, and there is, of course, similarity between many of these kinases, and there particularly is similarity between MET, ALK, and ROS1, and Crizotinib, of course, is approved for ALK and ROS1. There is also, NCCN does note Crizotinib as a potential option in this disease, and some patients do receive it. It can be effective as a MET inhibitor and is sometimes used. The other drug that sometimes does get used is Cabozantinib, which also is off-label but also does have activity against MET and is approved in other indications. In terms of the sort of resistance associated with Crizotinib, which again is not an approved therapy for MET exon 14 skipping patients, is that it is really that it has very little penetration into the brain. And of course, as we know in management of patients with lung cancer, brain metastases are a very significant problem, and that the ability to effectively treat brain metastases is important. I don't know that we have good data on what the effects of Crizotinib are specifically in MET exon 14 skipping patients, but what we do know is that the brain penetration that we've seen in the approved indications is generally quite limited. In terms of acquired resistance, I think that it's an important question to address, but to date I would say we don't have a tremendous amount of data on what are the drivers of acquired resistance, and I think that's something that at the time when we do have approved MET inhibitors, I think we would be hopeful to be able to do research in those very important questions. As you know, in other settings, particularly the EGFR mutation setting, studies of acquired resistance over time were able to really move the field forward.